Yep, that's it. We are on. So hi everybody. Hola.
Did you check? It's online.
We're live.
Yeah.
I see it clicking.
I think we're live. Because there's a gap between what we're seeing here and what is being delayed.
Yeah, it's okay, Thomas. We can start.
Yeah, we can start.
Okay, hello everybody. Olá, amigos. Bom dia. We're here again. Today we're with our fantastic surgeon, Dr. Dayan from Chicago. And please, Steve, it's an honor to have you here with us. I think for the audience and our friends that are watching us, it's going to be an adventure, a nice adventure. So please welcome and feel you're already home.
All right. Well, thank you so much, Lucas and Thomas. I appreciate you inviting me to do this lecture. And I'm here in Chicago where we have a nice day. But it was snowing yesterday, which is always kind of unbelievable. But today it seems a little bit nicer. And hopefully we're getting over this curve. We're at the peak or just kind of on the other side of it. So we're all getting very optimistic that we'll be back in the operating room fairly soon. So today I'm going to talk to you a little bit about endonasal rhinoplasty and some techniques for narrowing the tip via an endonasal approach. I'm going to go ahead and pull up my lecture.
Steve, before starting your lecture, can you tell us about you, a little about your story, your life? How did you get here?
So I'm a facial plastic surgeon in Chicago. I'm a clinical assistant professor at University of Illinois. I've been in practice 20 years now. I trained at University of Illinois with Tardy and Toriumi, and then I did a fellowship with Steve Perkins in Indianapolis. After that, I came back to Chicago and joined Dr. Tardy's practice. And after Dr. Tardy retired, I stayed on and I built the practice from there on out. My practice is it's very multifaceted. I do quite a bit of surgery, but I also do a lot of other things. Non-surgical is a big part of my practice now. It's about 50% of my practice, doing things like neurotoxins, fillers, and lasers. And I also have a large research division. So we do a lot of clinical trials, phase 2, 3, and 4 clinical trials. And that's something that I really enjoy, and I enjoy more and more as I get more mature in my career. As far as rhinoplasty, I did quite a bit of open when I first got started. I converted about 6 or 7 years into practice into closed, and I just absolutely fell in love with endonasal rhinoplasty. I find it very elegant. While it's not for every patient, clearly there are indications for it, but neither is open for every patient. So I find that if I can get a patient who's a good candidate for endonasal, I will try to do endonasal. And because I've been kind of specializing it, I get a lot of patients that will come to me in particular because they want endonasal. So I tend to self-select those patients now. And that was what Tardy was doing also. So I feel like I'm staying within that same lane. And I find now that I can do quite a bit endonasal. And I have a fellowship program in Chicago and through the AFPRS. And we welcome visitors anytime people want to come to learn techniques. And Chicago's a great place for rhinoplasty. As many people know, there's a lot of great physicians in Chicago who are doing rhinoplasty. And Chicago is the best city in America 6 months out of the year. And the weather's nice. In the winter, you might not want to come, but we welcome you to come in the summer and enjoy our lakefront and enjoy our pizza, hot dogs, and the Chicago Cubs. So that's a little bit about me.
Chicago Bulls.
Chicago Bulls.
Chicago Bulls. Chicago Bulls. Hey, Steve, I want to just tell people a quick story about how I met you. It was in 2015. In 2014, in fact, I sent you an email asking for an observership with you, and you answered me saying that I could go to see you. And then I was there in 2015 with you for a couple of days. I went to your office in the morning, and you received me, and there was a breakfast. There was a breakfast for me. My name was on the table. You gave me your book, subliminally exposed. Yes, a very nice book. My brother is showing it.
Yeah.
I think that everyone that works with facial plastics should read it. Very interesting, all your concepts. And you gave me your book. You gave me a folder with some of your articles also. I stay with you for the day, seeing you dealing with your patients. It's very. I was amazed to be there. And then the other day we went to the OR. I saw you doing 2 rhinoplasties, endonasal rhinoplasty, and in some fat grafting to the jaw. I think, yeah, to the jaw. It was perfect. So I know you were very kind, and I know that if anyone here wants to see you, I know that they're gonna have a good time with you there. So thank you, Steve, for being here with us again.
It was my pleasure, and it's all I love having people come in from around the world. I learn as much as I teach, and it's a great collaborative experience for me as well.
Yeah, can imagine. Thank you, Steve.
If I could really quickly mention the book that you showed, Sublimely Exposed. I wrote that. It took 4 years to write, and I published it in 2014 or 15, and it went on to become #9 on the New York Times bestseller list. And that book changed my life because it really made me think differently and opened up a lot of different doors for me. And now I spend a lot of time writing and teaching based on those. It's really a philosophical book on the philosophy of beauty and attractiveness. So it's a passion of mine.
Very interesting. Very interesting. Everybody should read. Everybody.
Yeah, everybody should read. That's why I brought it here. So it's amazing for all of us that work with, especially facial plastic, should read it.
Yeah.
Thank you. All right. So should I get started with my talk?
Yeah. Share the screen.
Yes. I will put it here. Yep.
Okay. So do you see my screen?
Yeah. It's okay.
Okay.
Perfect.
So I'm going to go ahead and get started. Can you see my face too, or just the screen? Just the screen.
No, we see your face on the right side of the screen.
Okay, great.
Yeah, we're seeing you.
For you, is just your presentation.
So I'm gonna give a little insight into my experience with it. As I said before, narrowing the nasal tip endonasally, and I think it's when we're going to talk about the nasal tip, I think today you have to talk about selfies because this is one of my daughters, and you can see that they are great at taking selfies, and selfies are bane of our existence in some respects because we all know as physicians that selfies expand the size of the tip up to 30%, but patients don't recognize this, and they come in often and say, I want a small nose, I want a small nose. And it's this constant negotiation with patients to say, well, I can make your tip smaller, but if I make it too small and it looks good in a selfie, it's not going to look good in real life and you can't breathe. So I found myself constantly having to navigate this issue with patients and saying to them, listen, let's look at my photos that I take that are natural photos. So that's a frustrating new concept. I think it's only come about in the last 3 to 4 years, is how to get these patients to have realistic expectations about the size of their tip. And the reason why I want to bring this up is because I have many patients who come in who had reductive rhinoplasties. I call them reductive rhinoplasties. This is Jock Joseph. And for about 70 years, rhinoplasty was done in a reductive manner. It was endonasal rhinoplasty. Cartilage was removed. The nose then collapsed down, and it was a smaller nose. But we had many tips that got too small, and then we started getting bossa formations. Back then, they really weren't putting grafts into the nose. They weren't stabilizing the nose. They were just removing cartilage, and they got these tiny, small tips. And you predicted what was going to happen. If you removed the cephalic margin, you'd reduce some of the volume. The tip would rotate. That's kind of how we were taught. I believe these are Jack Anderson models, and this is Dr. Tardy's model. But we were taught, like, remove some cephalic margin trim, the tip will rotate, remove a segment of the lower lateral crus, and it'll rotate even more. And this was all done endonasally without any form of stabilizing the tip afterwards. And you can see that tips would be like this. And this is a narrow, very narrow tip, but very common of surgeries that were done in the 50s, 60s, and 70s with these reductive and predictive approaches to the nose. And for these reasons, I believe the open rhinoplasty became so popular because we saw so many noses like this that collapsed. While a lot of noses looked okay, there was too high of a percentage of noses that were collapsing, getting notching in the alar rims, and people with breathing difficulties. So I think what becomes important is if you're going to do an endonasal approach, you have to put in cartilage grafts. So what I learned from the open was all these grafting techniques. And what I tried to do is take from the open the philosophies of grafting and using that in an endonasal approach. And then closing all incisions, not leaving them open, because many times in the past, in reductive rhinoplasty, traditionally doctors sometimes wouldn't even close the incision. They just let everything collapse back into place. And I think that caused a lot of problems. So let me show you a little bit about the evolution on endonasal rhinoplasty as I foresee it. Cephalic margin trim. And this is often, it can be done very easily. You can see making an incision through the transcartilaginous, through the lower lateral cartilage. You can mark it out if you want, or you can stick a needle through the external surface, through the internal surface to mark exactly where you want to cut. I oftentimes just look at it, and I've done so many thousands of these now that I just eyeball it. But some people, if you want to be sure that you make it symmetric on both sides, you can mark it out and measure it. So here's a transcartilaginous approach, and you can see my tip of my scalpel there, and I'm just going through the lower lateral cartilage. And I try to keep at least 8 to 9 millimeters, I would say, of lower lateral cartilage in place. I come around to the complete transfixion incision. And then there's the lower lateral cartilage. It pops out. I make a little wedge there, or a little ledge, so I can get the skin hook in, and then I can easily dissect out my lower lateral cartilage while keeping the vestibular skin intact, because I know vestibular skin is important that I close it, because if I don't close the vestibular skin, then I risk getting a stricture in that region. So here's removing the lower lateral cartilage. And it's also very important to hydrodissect, and I'm always teaching the fellows how important it is to hydrodissect really well in this area, because like any else, if you hydrodissect, the planes become even simpler. And you can see how it's not too difficult to do. That's lower lateral cartilage. And this is after removing both sides. And immediately you see the volume reduction. And that's one of the beauties of endonasal rhinoplasty that I really like, is right away you can see the volume reduction, and you see what you got. Whereas with open rhinoplasty, you have to open the nose, close the nose, and keep looking. And every time you open and close the nose, you lose a little bit of perspective. Right now, real time, you see right away your volume reduction, and you can see that it's symmetric. And that's one of the beauties of it. And then afterwards, this is a patient with just a little volume reduction in the cephalic margin. You can see slight improvement. If you look closely, she's full here, and then afterwards, it's gone. And that's a typical volume reduction in the area with removing a little cephalic margin trim. Once again, you can see this part's gone right here, and it's just brought in a little bit. You can see it narrows a little bit. The tip rotates a little bit. And that's a little volume reduction. It's another patient, similar. Of course, you always have to be cognizant that you don't get too much alar collapse here. So if someone has very cephalic margins, you want to be careful that you don't drop, that you make sure this is supported. So every patient gets an alar rim graft, just about. Almost never doing. I would say 95% of patients get alar rim grafts to protect the margins here. And I don't get any notching as long as I put in alar rim grafts. Although you do get a little lifting of this, which is common, you don't see notching. So that's really important for me. Okay, so that's cephalic margin trim. Now I want to show you another little nifty technique, endonasal domal binding sutures. So this is an attempt to narrow the tip without taking the lower lateral cartilages out from their native beds. So I raise a vestibular skin flap just underneath the dome, and I do it on both sides, raising a little vestibular skin flap. So for a patient like this, so if I want to narrow her tip and I don't want to open her, and it's too wide for just doing a cephalic margin trim, because if I just do a cephalic margin trim, you have all this dead space in here, and the tip will still be too wide. So I want to bring the domes together. Now, in the past, I would always deliver these, but then I said, well, I don't really want to deliver it. Is there something I can do without delivering it? So I created this technique where I raise these two little vestibular skin flaps, and then I take a suture, a 4-0 PDS, through the cephalic margin trims, and I suture the domes together. And I'll show you how this is done to narrow the tip. Now, it's not I don't get as much narrowing as I would if I open the nose or if I did a delivery approach, but I do get some narrowing. So here's how it's done. You can see raising vestibular skin flap just underneath the dome there after I've already done my cephalic margin trim. So I've done my transcartilaginous approach. lifting a little vestibular skin flap. And you can see dissection is minimal, and with less dissection, less swelling, and you don't reduce a lot of the stability of the nose, and that's really key. So now I'm releasing some of the ligaments between the domes so that I can bring the domes closer together. And then I'll take a suture, and this suture goes through one cephalic margin on one side, and then I pass it between the nostrils out the other nair. And this is a really simple technique to do. It just takes, I mean, no more than 5 minutes to do this. And of course, you can always do it multiple times. So if you don't like it, you can come back and do it again. Sometimes I leave it a little bit of a loose because it can get too tight. So I'll leave it a little bit loose, just enough that it narrows it, and then I think it'll scar how I want it to after I put on this cast. So that's just a little bit of narrowing in the tip. And it's a nice little nifty technique, super simple and easy to do. And I can get some narrowing. You can see here she gets a little more narrow, and that's without having to open or without having to do a delivery approach. All these patients, almost all, as I said before, 95% get alar rim grafts, unless they have really heavy alar hooding. I almost always put in these alar wedge grafts. And these are super simple to do. It's an old video, as you can see. It's kind of crusty old video, but it's a simple technique with a iris scissors coming from base, superficial. I try to stay as close to the rim as possible and make sure that I get this in there. And it slides in, and that's really nice, simple way to protect the external valve as well. So alar rim grafts, and you can see here, this is photos, pocket here, pocket goes all the way up, and then slip in the graft. I put in a 5-0 fast absorbing chromic here. It's key is that I get this as close to the rim up here, because that's how you want to protect the soft tissue triangle. That's the key, is the soft tissue triangle. That's the area that I really want to protect. And you can see here's another example of a tip with those approaches. And you can see how nice this is protected here with those strong alar rim grafts. The domes are brought closer together. It's pretty wide, but just some endonasal, you can really get nice narrowing of the tip. Now, delivery approach is something I did a lot of in the past. I'm doing much less of this today, but in someone with very thick skin that I don't think I'm gonna get enough narrowing, and all I need to do is just narrow the tip a bit, and it's a very symmetric tip, I will still do delivery approach. And the delivery approach, my technique for that is first I make a complete transfixion incision. I connect it to an intercartilage incision, so this comes around here. So this is connected. Then I do a rim incision, or a marginal incision, just like you would do for an open approach. I release the tissues above it, so I free up the lower lateral cartilage above it, just like you would do for a open approach. And then I put it in through one end of the incision, out the other end of the incision. So it goes in through one end, out the other end, and I can able to deliver it. So you see it goes through the intercartilage incision, and I can deliver the lower lateral cartilage. And then I can work on it. And so here's one dome. Here's the other dome. I bring both out through the same nostril. I may suture them together. Sometimes I put a tip graft, and I can hold it in place with a 30-gauge needle and sew the tip graft in symmetrically also. Here's the lower lateral cartilages. You can see doing cephalic margin trim. So I deliver it, a cephalic margin trim under direct vision, just like you do under an open approach. Then this is, sometimes I do a single domal binding suture here. Here's bringing the two domes through one side, and you can see they're nice. They're already put a single dome suture in there, match a suture. Then I bring them together. This is the cephalic margin from one of the lower lateral cartilages, and then secured across the tip. So I put a little tip graft in there. And then this is what I call a soft tissue triangle graft. This goes along this in the soft tissue area, and it makes a nice transition from the lower lateral cartilage to the tip. And whenever you're going to do these domal binding sutures, you have to be careful because you can get notching in the alar rims. So that's why I put the cephalic margin tip graft. Here's a video showing what I just showed you in a schematic, in photographs. So this is doing a single dome suture. And this is usually a 5-0 PDS. And then I do the same thing through the other side, and then I bring them two together. I bury this between it at 5.0 PDS. Anytime you want, you can also open the nose. There's times when I've gotten all the way to where I'm at the end, and I don't like the way it looks, and I open the nose. And it's not a problem to do that. So that's one of the nice things about learning endonasal is you can always open the nose in between at the end if you're not happy, and you're not gonna cause much a problem. And I still to this day I do that on occasion if I'm not happy with the way the tip is looking. One of the keys I think is leaving this divergence here. If you sew this too close together, you get that uni tip. So I suture the cephalic margins of the lower cartilages when I'm doing the domal binding suture. So I'm suturing it up here, but I'm leaving this divergence here, which is key to having the two tip highlighting points. And then oftentimes I'll use this soft tissue, the cephalic margin tip graft I put between the intermediate crura. And you can see like someone here who's got this bifidity, and after delivering it and putting in that little piece of cephalic margin tip graft, it works really well. And I love using that. I use it a lot now, even when I open a nose, to make the tip look more uniform. So you can see this was a delivery approach, and look how wide it was. So my previous technique I showed you of an endonasal domal binding suture wouldn't be able to get that narrow enough, so that I have to deliver in order to get it narrow enough. And that is a really it's a good technique. Here's another one that was really wide, same thing, and I can get it significantly narrowed with that technique. Let's see. So this is a this is doing a tip graft also after delivery. So you see sometimes I will deliver the cartilages, and then I can do a tip graft if I want. Now, the key to this is getting it symmetric on both sides. So you have to really be cognizant that when you pull one dome through to the other side, it's going to be a little shortened and it's not going to look symmetric right away. So sometimes I go back and forth with the tip graft to make sure it's symmetric on both sides. You may want to measure beforehand where you're going to put the sutures. So sometimes you mark beforehand with a marking pen exactly where you want the sutures and where you want the graft to go. I don't do that anymore, but I did that early on to make sure that I got this symmetric. But it's, once again, it's not very hard. Is there advantage to doing this versus opening it? Well, you know, there's an argument here that if you're going to do all this, why not just open it? And I think that's a good argument. But I will tell you, once again, I have a lot of patients who come to me and say, Dr. Dayan, I don't want a scar, even though we all know the scar's not that relevant. I mean, I think I've had 1 or 2 people in 20 years complain about the scar. It's rare to complain about a scar from an open rhinoplasty. Having said that, I have a lot of patients who really say, I don't want a scar, and this seems to be really important to them. So I say, okay, I'll do it endonasal, I'll deliver, and I'll do a tip graft with this, but I reserve the right to open if I have to. And they're usually okay with that, but they seem very pleased with the fact that I can do this through an endonasal approach. And that's in some respects a marketing advantage for me as well. So you see how I have to make sure I get this symmetric on both sides, and it may look a little distorted right now because it's leaning off to one side. But once I put the tip back into its native position, it goes right back into place. And also, once again, I think that you maintain a lot of stability of the nose by not opening it. I think there's so many different ligaments that we violate or when we open the nose that causes the nose to be weaker. So now the tip graft's in place, and now oftentimes I'll do what's called a soft tissue triangle graft. Let's see. Soft tissue triangle grafts are for this. So you see this region right here. This is at high risk for getting notching. So if I see this beforehand, I'll put in this graft afterwards. And this graft I think is really important. It goes right there. You can see that right in this region right here. And that's a really important graft for me. I can use septal cartilage, you can use ear cartilage, you can use cephalic margin cartilage. So there's a lot of different options. Oftentimes, if I'm going to use a cartilage from the septum, I may morselize it a little bit to soften it so that you don't get irregularities in this region, because this tissue is very soft. It's not as forgiving. And I usually sew this in place with a 6.0 PDS is my preferred choice. So 30 gauge holds it in place. You see there's the tip graft that's in place. Sometimes I put a little soft tissue behind the tip graft to also blunt it so you don't see the edges of it. And then this I sew in pretty easily, and sometimes I'll sew it to the tip graft as well. Once again, this could be done through an open, maybe a lot easier for people, but if you can do it through a closed, that's maybe an advantage. And that protects the soft tissue triangle, which I think is important. I'll also put an ala rim grafts in as well with that soft tissue triangle graft. And then, yeah, here's the rim grafts that are going in. And if I'm going to do a delivery approach, the rim grafts go in as I would do an open approach. They go from medial to lateral, which is different from how I do it normally when I'm doing, if I'm normally doing endonasal, if I don't deliver the tip, I go from the base towards the tip or from lateral to medial. This time it goes from medial to lateral, just like you would do in an open approach. I think these grafts are really important and makes a big difference. So here, going from lateral to medial, or from medial to lateral, excuse me, and this is what I do through a delivery approach, and slip the graft in. Oftentimes I'll do a 6-0 PDS to secure it in place, and I make sure this goes along the soft tissue triangle, so I get additional support there. Now I'm going to show you another technique I call endonasal domal cinching suture. So if I want to keep these in place and they're not too far apart, but I want to narrow just a little bit, so it's not as much as I don't need to deliver the tip. I don't need to do an endonasal domal binding suture I showed you before. This I call a cinching suture, and all this is a 4-0 fast absorbing. It goes between the domes. So I'm taking a 4-0 fast absorbing cat cut. I'm going right between the intermediate crura. And it's a simple suture I do at the end. It's really is quite simple. So here's a 4-0, and I'm grabbing both domes. And this is at the very end. If I think, you know what, it's just a little bit wide and I'm not happy with it, and I want to narrow it just a little bit, I'll put this in there. And it just goes back and forth through and through the domes. So it doesn't give a whole bunch of narrowing, just a little bit, but sometimes it's all I need to get just a little bit more narrowing of the tip. And then I just I tie it down. I can do 2 or 3 of these if I really want to get a little bit more. I'm using 4-0 plane because I'm going through vestibular skin. And yeah, sometimes it's all I need, just a little bit more narrowing, and I'm able to get it with this type of suture going right through the domes right there. Here is, sometimes I may create a tip graft outside the nose and then put it in. Now, the truth is I don't do much of this anymore because usually if I'm going to do this, I'll open the nose, but it is possible. I make a pocket and I do a rim incision and then I slip the graft in. But it's important that I thread it through and I sutured on both sides, because this can migrate. If this is not put in, it's got to be fixated. So I fixate this in place, and that makes a big difference. If I don't fixate it in place, it'll move, and that won't look good. And so this is a patient here who needed it. She has some asymmetry here, and that's where I was an ideal patient for that. So you can see a little bit of, it gives a little bit of fullness here, and I got rid of some of the bifidity between the domes. Sometimes this is a patient who wanted revision surgery. He had a bulbous area in this region. It was really bothering him. So sometimes I'll take a little graft and I'll put it just over the external portion of the lower cartilage or just under it. And here's going over it, or times I go under. So here's someone who wanted revision surgery, but he didn't want, he was busy, he was working, and I didn't really want to do a whole open approach on him because he didn't seem like he was a candidate for it, but he was really bothered by this. So I said to him, okay, I can try something small. I go, I'll do an hour procedure on you. I can probably get a little bit better. Or I need to open your nose, and it's going to be a 3-hour surgery, and we're going to need ear cartilage, possible rib cartilage. Or I can do a small procedure, less than an hour, and maybe give you some improvement. And I did that. And this is a small, quick procedure. Now, could I have done better with a big open procedure? Perhaps, but this is just a 1 year later, he's looking a lot better. But just even a week later, 2 weeks later, he's able to go back to work. And it goes from here to here. And that's a pretty reasonable result for a quick endonasal hour procedure on a revision surgery. So yes, he's a candidate for an open approach and for a complete revision. But not always. You'd be surprised how many of these patients you're able to make better with a simple approach. Sometimes it doesn't require a complete revision of the nose to get these patients to be happy. And the truth is, the goal of these procedures, in my opinion, is making the patient happy. It's not necessarily for me to have a great photo to show all of you. It's to make sure I reach patient satisfaction. Here's another patient who had a little bit of collapse here. So I put that lower lateral cartilage graft just at the lateral portion of the crus into the piriform, and she got better. So then it led to this new technique called lateral crural underlay grafts. And I published this, I think in 2014 or 15, on my first 30 or 40 cases. I've done well over 200-300 of these now. And this is where I take a lower lateral cartilage graft and I put it underneath the lower lateral cartilage, between the vestibular skin and the undersurface of the lower lateral cartilage. So it's a really great technique that many of us do through an open approach, but I was like, well, can I do this through a closed approach? So I'm always looking at ways to make my life simpler. And certainly this made my life simpler by putting in this graft in a non-delivery. So I leave the lower lateral cartilages in place. I make a small little incision on the edge of the lower lateral cartilage. I lift a pocket on the vestibular skin side. Now the key here is hydrodissection and getting underneath the perichondrium. Otherwise you can rip this flap. And if you rip the flap, then it's not gonna work. So that flap has gotta be pretty much intact. And I raise it down past the lateral portion of the lateral crus all the way towards the piriform. And then I take a cartilage graft. I can make it curved or I can make it straight, however I want to use it. And I place it into this pocket. Now you can see it going into the pocket here. I can extend it past the piriform if I really want to improve the breathing and make sure that the nose is stable. But I find that if I go that far lateral, that there's a bump afterwards that patients don't like. So I've actually made them shorter now. So here's someone who's got recurvature of the lower lateral cartilage. I know that if I do a domal binding suture, I'm going to bring this in and they're going to have trouble breathing. So I need to amputate this, or I need to put a lower lateral crus graft there. And that's what I do. I put that graft under there. I suture it in place with the 5-0 PDS. This never leaves its native bed. So it's really a nifty technique. And here it is. Here's the cartilage graft. Here's the vestibular, here's the native cartilage, the lower lat, and I suture them together with a 5-0 PDS, and then I close it. So it takes about 15 minutes per side. It really doesn't take a lot of time. So here's the technique doing it. This is almost real time. And this is removing first I do a cephalic margin graft, a cephalic margin trim. So I remove the cephalic margin trim like I showed you early on in this lecture. Then I get a graft from the septum. And as I said, now I'm making them smaller. I used to make them a lot bigger, and I'm thinning them. I find that I've had to take 2 out where patients thought they were too thick. And unlike in an open approach, where we have a little more leeway, I find in an endonasal approach that these grafts have to be smaller. They're less forgiving. And you don't need them as strong. So I slip it into that pocket, and then I suture it with the 5-0 PDS. The hardest part about this is that your neck and back hurt from having to look underneath to get this graft in place and to suture it. That's a 5-0 PDS. I put 3 5-0 PDS sutures in, and I suture it. And it's a lower lateral crural graft, and you can see how well that works. And that was something that many of us do through an open approach, but I figured out I could do it through a closed approach. And you can see how it gives nice narrowing to the tip, some rotation to the tip, some shape to the tip. Here's another patient I used it on. Here's a patient I did it on with a very bulbous tip. 3 months later, I was like, oh boy, it's still too bulbous. I probably should have not done that. 6 months later, she's still looking kind of big. And I was like, it was probably a mistake. But she came back at a year and it started narrowing. So I realized that even if I put these in, I didn't bring the domes together, I didn't do a domal binding suture. I just put in that lateral lower crus graft. And look how the tip just starts narrowing over time. So it is a technique that improves with time too. I've noticed it get narrow over time. And you can see afterwards, she's narrowed, but look how strong that alar base is. That rim is really strong, so worked well. Alar wedge excisions, I know a lot of you do this pretty routinely. I'm not sure if my technique here is any different than any of yours, but I find this a very valuable thing to do to get the patients narrowed. I don't do much of it. I do it on occasion. It's a very simple thing to do in the office if I want to do it afterwards. And I don't like the scars if I don't need to put a scar, because I'm oftentimes trying not to put scars on patients' faces because they like the scarless rhinoplasty. But I do it on occasion, and they get nice results. But this is what I really want to show you, this nasal base cinching suture. So this is a technique I use for someone who's got a very wide base, someone like this who comes in, and there's just no way alar wedges are going to do enough. So I'll take a suture and I'll do a 3/0 PDS or a 2/0 PDS, a large suture on a Keith needle, and I'll weave it underneath and cinch the base together. And then I'll do it through alar wedge excision. So let me see if I can show you the technique here. So here's someone with a very wide base. And I'll remove I'll remove a little bit of the wedge of the alar base right here. I'm pretty generous with this. I don't like making incisions on the outside of the nose, so I try to keep it within the nose. Obviously, I leave about 1 millimeter or 2 at the base so that the sutures, so that there's the native alar facial junction. So that wouldn't be enough, I don't think. The person really wants it narrow. So here's a 4/0 Keith needle with a 3/0 PDS suture. And I'll come down through here and I make sure I get deep enough and I go right underneath the nose, out the other side. And this is really a simple technique that works incredibly well. Once again, this can be done in the office too. And I have done this in the office afterwards if someone's not happy with if it's not narrow enough. And you can, test tie it. You can, and if afterwards the patient's not happy, in theory, you can go in there and cut it out. So it's really a forgiving suture as well. Obviously, you have to stay deep enough here, but you don't want to get too deep. You want to make sure you don't go through the oral mucosa. But really not difficult at all to do. Very simple technique. And then you can kind of test tie it as you wish, and it works incredibly well to narrow the base. And then I suture it close. So someone like this with a really wide base, I can get her a little more narrow. And so that's a nifty technique. So in conclusion, I do a lot of things through the endonasal approach, but I'm using a lot of grafts that I learned in the open approach that I now convert to doing in an endonasal approach. And if I do this, I feel like I get really good results in many of my patients. And while not all patients are candidates for endonasal rhinoplasty, neither are all patients candidates for open rhinoplasty. So I think a combination of both in your practice really adds to your portfolio and gives you an opportunity to treat a lot more patients. Thank you for listening. Are there any questions for me that I can answer on that?
Yes.
Yes.
First, how is your percentage of closed versus open nowadays?
Probably now I would say I'm 80 to 90% closed.
Okay. And how do you think I know you're specialist in first impression, but the first impression when the patient takes the cast off.
So that's a really good
question. How important is it in the mind of the patient?
Much more important than we realize, because every time before I operate on a patient, I say, okay, it's going to take a year for you to get the final result. And I say that no matter what kind of surgery I do. But I know so well that if I'm going to do an open rhinoplasty and work on the tip and put in grafts or put in soft tissue, for sure they're going to be a lot more swollen. And I know it's right away, they're probably like, well, it looks a little big. But with endonasal, almost certainly they're going to be happy when I take the splint off. And I rarely get bruising and swelling. I'm very fortunate to have very little bruising and swelling. So they walk around the city with the splint, they take it off afterwards, and that helps a lot from a marketing purpose where patients are like, wow, if I go to Dr. Dayan, I'm going to have no scars, no bruising, no swelling, and my results look good, pretty immediate. So it's a huge advantage in reducing bruising and swelling.
Yeah, sometimes I make some jokes with my friends saying that I would like to be a 7-day surgeon. When they take the cast off and they are happy, so I don't have to explain that the edema has to go off and that it's not a bit to the left, a bit to the right. No, right. It's going to get thinner. So I think, for example, spreader grafts, they make the nose too big and it's difficult for the patient to understand that it's going to change. So I would be very happy that I could have all my patients like that.
I agree. It's, of course, rhinoplasty is a difficult procedure, and half the difficulty is just managing the patient's expectations, or maybe even more than that.
Yeah. Steve,
Yes?
I have a question. Congratulations for your lecture first. And we see that nowadays residents are learning much more from the open approach than from the closed approach. Do you see this as a problem?
So I think that's a great question. I wrote a paper when I first started doing this. I think it was 2010 or so, and I published it in
The Pendulum.
Yeah, and the pendulum is going too far. And I wrote that paper. I went to go visit someone doing nasal rhinoplasty, and I got really impressed. And what I realized, like 80% of training is done open, and obviously it's a lot easier to learn the open approach, and it's more comfortable. But when you first get started, an open approach is not without its difficulties. And when you open the nose, while you can get a great result, you can also get a much worse result too than when you do endonasal. You leave things in place. So I think it'd be great to teach endonasal also. It's a lot harder to teach it, of course, because you have to know the anatomy. And I think you almost have to start open, because once you start open, you know the cartilages, you know what you're looking at, then you can go in endonasally. So I think it's important to start out open. I think it's important to learn that. But where do you learn endonasal today? It's very hard because very few teach it at a higher level. So, but it's an elegant procedure for so many patients, and especially like these revision cases. There's many revision cases. You'd be surprised. You don't have to take the nose apart. You can do some minor grafts, and you can make some minor pockets and really make a big difference, and patients are really happy. And it's not this 4-hour procedure with cartilage grafts and rib and ear cartilage for all patients.
Yeah, I agree with you, Steve. I agree with you. Me and my brother, we were trained in closed rhinoplasty at the residency, and then we were trained in closed rhinoplasty. I did I think 70 rhinoplasty last year, resident, all of them closed. So then I started doing the open approach, and I think I agree with you. It's a very nice technique, and even in some revisions, so you don't need to open up all the nose again. If you can go to specific places and treat it, but you have to learn how to do the incisions, where the incisions are. So it's very important to learn both closed and the open approach. And we see that nowadays people are just learning the open approach, and the closed approach it's not being taught by surgeons.
Yeah, that's it, Steve. Here in Brazil, my last year was 2005, my last year residence. I had 150 rhinoplasties in my last year, and only 3 of those were open.
Wow.
Yeah, at that time, so it's 2005. Now 2000, I can tell you, since 2015, most of the residents are not being trained on closed approach in Brazil. It changed too fast in 10 years. So the guys that are younger than I, or younger than Tomas, they usually don't know how to do closed approach. And the main problem, in my opinion, is for revision. It's okay if you do open but do the right surgery with few grafts, with few resection. But the problem is at the revision. When they have a minor revision, they cannot do without opening the nose. Yeah, and that's a big problem. A big problem. And the second problem that we have in Brazil, that Brazilians are not trained in nasal reconstruction. So I think the nasal reconstruction should be the first step, and then go to rhinoplasty, because you can learn all the techniques of soft tissue and grafting and internal lining. And most of the Brazilians are not training in nasal reconstruction. That's what I think we should change here in Brazil.
It's it's interesting. You bring up a void, or an area that really there's a need to teach this. I know Pietro Palma, a good colleague of ours, does a lot of this in Milan, endonasal rhinoplasty. Him and I always share ideas and techniques and philosophies. there's probably a role for putting together a curriculum of endonasal approaches and teaching.
Yeah.
Okay, so let's go to the questions of the audience, Tom.
Yes, let's go to the question of the
first
audience.
question is about the Pitangui ligament. I think because of this new trend of preservation rhinoplasty, and most of the people are trying to preserve or to reconstruct the Pitangui ligament. So as you answer this question, I would like to know also what do you think about preservation rhinoplasty?
So, okay, I think the less dissection you do, the less destabilizing you do of the nose, and I think there's a lot of advantages to that because you don't get as much swelling and you don't get as much deviation of the nose afterwards. So I'm really a proponent of less dissection. If I can preserve ligaments anywhere in the nose or preserve any sort of the structure, I'm going to try to do that first. So if that means not, when I take down the dorsum, the way I do is I leave the upper lateral cartilages. I don't reduce them. I just take down the septum, the dorsal septum, then close the upper lateral cartilages back down. I do minimal osteotomies today. And I think that's also helpful. I try to keep retaining ligaments intact and as many ligaments as possible intact because I think that allows the nose to maintain its structure. And you'd be surprised, a lot of patients don't really come in saying, I want a completely different nose. They want their nose just a little bit better. And sometimes I think we get a little bit heroic where we take the nose apart and put it back together because we get a beautiful looking nose, but that's not necessarily what the patient wants. They want their nose, but a little bit better. And that's not all patients. Of course, you have to really read your patients and know your patients. And perhaps I get patients who come to me because they don't want as much done. But I do my best to preserve as many structures as possible.
Okay, agreed. So
Lucas?
Oh, yeah. Okay, great. The next question is Guilherme from the south of Brazil. He's asking, that's a question that I would ask you, but I'm happy that Guilherme has asked because your last lecture in Brazil, the last time, you taught me a nice trick to deal with unhappy patients, and I do it with every unhappy patient. I have my notebook.
Me too.
And
yes.
I do exactly what you taught me. So I would like you to repeat, because I know that there are a lot of people here that couldn't watch you in Curitiba. That's the best thing you taught me, from far. I use it, and I'm very happy with it.
Okay, so this always works, but it always takes a piece of you at the same time.
Yeah.
Yes.
Your soul. You told me it takes a piece of your soul.
It takes a piece of you. You go a little bit smaller after you do this, but it always works. So if you know you have to go into a room and a patient's unhappy and the nurse says, doctor, your patient in room 3, she's 6 months out from a rhinoplasty, she's not happy. You're like, oh, that sinking feeling. But here's the trick. A pair of glasses, a clipboard with a pen, and your chair close to the patient, a little bit higher than the patient level. You sit down with the patient and you say to the patient, what bothers you? And they're hysterical, like, oh, my tip is too big, my dorsum, this bump. You're like, okay, slow down. Tell me what bothers you. Number 1, the tip is too wide. The tip's too wide. Okay, slow down. Number 2, what bothers you? Number 2, the bump on the left side of your dorsum. Okay, bump on the left side of your dorsum. Okay, slow down. Number 3 bothers you. And then they're like, well, the nostrils uneven here. Okay, number 3, nostrils uneven. Okay, number 4. And then I get to like number 9, and I'm like, is there anything else? And they're like, no, that's it. I'm like, that's it. Only those 9 things. Nothing else bothers you. You got all 9. Okay, now let's go through each one. I go, well, number 1, I can do this. Number 2, I can do this. Number 3, we have to give a little more time for it to heal. Number 4, there's not much I can do for that. You're going to have to live with that. Number 5, if we need to do a revision, I could probably fix that, but I think you'll be fine with the steroid shot. And number 9, and then number 8, that's going to heal with time too. So is that okay? Is that a good answer for you? And they're like, yeah, thank you so much. That answered all my questions. I super appreciate it. You're the nicest doctor. And they walk out and they smile and they're happy. And my staff always looks at me and they're like, how did you do that? I'm like, all I did was sit there and listen, but I come out, I'm like, oh, I feel like I got stabbed in the but
it really works. I
really works.
On regular basis with the patient, and I tell them exactly the same. Instead of, with this, these ones I can fix, this one I cannot fix, and from those that I can fix, maybe this one I need a piece of your rib. And what do you think? Not that bad. It's okay.
Yeah, that's funny. It works always.
Yeah.
Elena Thomas is asking about your last maneuver to narrow the tip, and she's asking about how it interferes in the upper lip. And I know you recently published a paper on tip and upper lip. I will share it here, and Thomas will share my screen here so people can see what I'm seeing.
Yes, I published an article that shows that if you project the nose, you also rotate and shorten the lip. So you bring the lip up. So oftentimes we don't realize that when we treat the nose, we're also affecting the lip. And I found that very interesting because now if I want to do fillers, if I put fillers underneath the nose, I can project the tip of the nose, but I can also treat the lip. So it's another way to treat the lip. And I figured that out. The two are very connected, the tip and the lip. So you have to be cognizant of that. And the question I think is a very good question that was asked. And it's important that I don't go into the lip when I do that cinching suture. So I stay just under the nasal base. And by doing that, I don't affect the lip. So it hasn't been an issue for me. I get more issues with the lip is if I put in a strong caudal septal extension graft and I project the tip up and patients smile, but they can't get a full smile. And that really makes patients unhappy. Usually it gets better, but I've had a couple of patients over the years that I've seen and that other doctors have done that have come to me that have this great projected nose that looks fantastic in a 2D photo, but when they smile, they're not happy. And they're like, doctor, my smile is not natural. What's wrong? Well, the reason why the smile is not natural is because their smile is not complete because it gets blocked right here at the nasal base.
Yeah.
They call it septal extension graft. So be careful with those.
Yeah. Yeah, we see it a lot.
Yeah.
We see it a lot here in Brazil.
One of the main complaints here, with of course, for the same reason you showed us in your lecture, is that patients are unhappy with their nose when they smile. And how do you deal with that when you talk to the patient?
Well, so it doesn't happen to me much anymore because I'm really careful to make sure that I don't injure the upper lip in that region. And if I put in a caudal septal extension graft, I do my best to not make it extend too deep into the columella, because that's really where you can affect the smile. Now, it's not uncommon after an open rhinoplasty to have some weakness in that area. Almost always it comes back. But I think you have to be really careful with your caudal septal extension grafts and even your columella struts.
Yeah.
Okay. George is asking about
fixing spreader grafts.
So I have other videos on endonasal spreader grafts, and it's a very simple technique for doing endonasal spreader grafts. Now, the one thing I've recognized is that if I keep the upper lateral cartilages intact, in other words, if I want to reduce the dorsum, I release the upper lateral cartilage from the nasal septum. I reduce the cartilaginous nasal dorsum under direct vision, and then let the upper lateral cartilages fall back down into place and suture them. Oftentimes, I don't need spreader grafts. So my need for spreader grafts has significantly reduced since I started that technique. Having said that, I probably put spreader grafts in 30% of patients I do endonasal. But by leaving the upper lateral cartilages intact, it makes a big difference because I can, on one side, I leave the mucosa of the septum is on the right side. I leave the mucosa pretty much intact, other than just the pocket at the top where I'm going to put the upper lateral cartilage in, the spreader graft in. On my left side, I may elevate the whole flap because I have to harvest cartilage. But if I put the spreader graft in there and I suture it caudally, so very near I put my first suture caudally and I'm able to anchor it there. And then posteriorly, all I need to do is get one stitch in, and it's usually not too hard for me to get it in once I have it stabilized caudally near the anterior septal angle. And then the other side is very simple because I leave the mucosa intact mostly on the septum, so it just sits on the bed of the perichondrium on the right side, and it's very easy to suture it in place. Then afterwards, when the upper lateral cartilages fall back over, it protects it, because by it falling back over, it doesn't. You don't see the cephalic portion of the spreader graft, because it's underneath the upper lateral cartilages, which are back in place. So I have videos on that, and if whoever's asking that question, if you want to reach out to me, I can try to get those to them so they can see it. Okay, if you want.
I'll do a comment on that. For spreader grafts, there are two tips I would give. One is do the transfixion incision that Steve already said. If you don't do that, it's much more difficult. And the second thing is to do two different pockets, one for the dorsum reduction and the other one for the septal harvest. So you have different pockets, and it's the graft doesn't fall down to the inner nose. You know, you do a small pocket to put this, reduce the dorsum, and then insert the spreader graft.
Good idea.
Yeah.
And next question, Tomás. Alessandro. About the planes, I think he's asking about the subperiosteal, subperchondral, subcutaneous. Is that
the planes?
I think it's the plane of the section.
So it's almost always, I try to get subperichondrial almost always if I can, except when I'm raising the dorsum, I'm just on top of the perichondrium. It's a bloodless plane. Almost every plane I'm in is completely bloodless. And that's a huge advantage to reducing swelling. And also, when you're doing endonasal, you want as little blood as possible, because you can't see if it starts welling up with blood. So almost always I'm in a bloodless plane. I'm subperichondrial in a lot of areas, like the lower lateral cartilages, the septum. But then when I'm raising the envelope, I'm just on top of the perichondrium and then subperiosteal.
Okay. I would like to ask a question about fillers in the nose. What are your tips? How do we should do, what we shouldn't do? And I know you're an expert on that too.
Yeah, I've published a lot on this. And on my Instagram, I have my technique, which a lot of people follow. It's a 5-point technique. So when I think there has to be extreme caution when you put fillers in the nose. It's the #1 area to get blindness. And if you're going to do it, you got to be really cautious. So how can you be cautious? One is it's much higher risk of blindness in a revision. Someone's had previous surgery, so keep that in mind. Two is if you're going to use a needle, you have to be super careful. I always use a cannula, a 22 gauge cannula. I believe it's a lot safer. I believe there's overwhelming evidence that 22 gauge cannula is a much safer cannula. Not a 25, not a 27, but a 22 gauge is very hard to get into a vessel, and that's been proven in multiple clinical trials or multiple cadaver trials. If you're going to use a needle, I believe you have to go down to the perichondrium or the periosteum and inject right on there with a small 30 gauge needle in a very slow manner, and not move your needle. So those are two caveats when you get started. I usually use a product. I use Restylane usually, and I like that product. I thin it a little bit with lidocaine. I do 3 little shots of local anesthetic. I put one in the radix. I put one just before at the super tip region. And I put one at the nasal base. So I have a little bit of local anesthetic, not 0.2 maybe completely, and then afterwards I fill the radix first. If I need to hide a hump, I fill the radix first with the product. I go down to the perichondrium with the 22 gauge cannula, straight down vertically, fill that up, which then leaves a little pocket there of filler. Then I make my second injection is in the super tip region going towards the radix. And I go into that pocket, which I know now is an area of safety because I've already filled it up with filler, and there should be no vessels there. And then I fill the dorsum as much as I want. Then my third injection, it goes tip straight down to the nasal base, like I'm doing a cannula strut, and I go down to the maxillary crest and just come right out like I'm doing a cannula strut, and that just gives nice projection and nice projection to the tip. And then I'll go into the tip and I'll go over the intermediate crura to make a little tip. At that point, the nose is pretty is pretty numb, and there's really little to no pain. This whole thing takes me about 10 minutes to do it, and I've been very successful with it. Luckily, I've not had any complications, but I have taken care of multiple complications from noses with fillers. So extreme caution advised if you're going to treat filler in the nose, more so than people recognize.
Okay, great. Tomas, we have an hour now. Do you have any questions?
I have a question. Maybe the last one, but I want to know what do you think it's necessary for a rhinoplasty surgeon these days to be successful, and how do you think it's the best way for improve your rhinoplasty?
That is a great question. That's a fantastic question. Okay, obviously you have to have a certain amount of native skills, artistically skilled and surgically technical skills. That is baseline. If you don't have that, you're gonna have a hard time being successful. And I think that most of us who are surgeons who choose rhinoplasty have that. But you asked a question about being successful as a rhinoplasty surgeon, and I really believe after doing this for 20 years, the hardest part about being successful, or the most important thing to being successful as a rhinoplasty surgeon, is managing patient expectations. Because really, you have to recognize that 30% of patients getting rhinoplasty want revision. Of all the surgeries that are done in aesthetic medicine, there's no surgery more difficult with a higher dissatisfaction rate than rhinoplasty. If you're going to choose to do rhinoplasty, you're going to choose a procedure and a field where you're going to have the most amount of dissatisfied patients of any other plastic surgery procedure. So let's say you're in practice and you're a great rhinoplasty surgeon, and you have a revision rate of 5%, which would be not too bad. You do 200 noses, that's 10 people a year. After being in practice for 5 years, you're starting to build up a fair amount of patients out there who are unhappy. And it's funny because the best surgeons oftentimes have the most negative blogs because they've been around a long time. They take on these difficult cases and do a lot of surgeries. So you have to recognize you're going to have some of these patients every year. And that's the bane of our existence, is having to manage these expectations. So the key is trying to screen them out beforehand, which we probably don't spend enough time doing. And then the other thing is, doing your best to not hurt them, and then being available for them afterwards. And that's just like we talked about how to make an unhappy patient happy. Like that is really probably the key to being successful as a rhinoplasty surgeon, is managing the patient expectations, because these are difficult patients, and it's getting more difficult now with social media and all the photos they're taking and unrealistic expectations. So it's a very difficult field. And I tell my fellows and residents, if you really want to, you sure you want to be a rhinoplasty surgeon, because you're picking not going to be so easy to do. So make sure you love it.
Yeah. I usually tell this to the patients. I tell them happiness in life is expectation becomes reality. So we have to adjust your expectation to what I think is the reality, is what's going to happen. And so if I could do this, I have fewer complaints. Otherwise,
yeah, that's it, Steve. Thank you very much for your lecture and for all your thoughts.
Before I said, Tomas, just to remember, who has never read this book? Is Steve's book. It's wonderful. I think all of us should read it. Subliminally Exposed.
Thank you.
Yeah, that's it.
Thank you.
Thank you, Steve.
We'll see you soon, I hope.
Thanks.
See you soon. Thanks a lot for helping us here in Brazil with your knowledge. Thank you.
Yeah.
My pleasure.
Thank you, Steve.
Okay.
Thank you. Stay safe. Stay safe. See you soon.
Okay.
Bye.
Bye.
Thank you.
Thank you,
Bye.
Steve.